Dr. Mahesha, Manipal Hospital, Bangalore, and Dr. Manish Malik, Vice Chairman Nephrology, SGRH, to occupy the chair. Kindly requesting you to invite our next speaker to have a presentation on ABMR and update.
I would like to thank at the outset the organizing team of this ISOT pathology session for having such a wonderful scientific schedule and the experts in the respective fields to speak on, and we listen to them. After hearing to the talks on post-transplant of some duration, let's move on to the acute graft dysfunction and the chronic, especially in relevance to the antibody-mediated rejection. And we have none other than Dr. Swarnalata Gowrishankar, who is a senior consultant pathologist at Apollo Hospitals, Hyderabad. Renal and transplant pathology has been her main interest, and she has been running a program on PDCC. Let's welcome Dr. Swarnalata, ma'am.
Wait karo. Wait karo.
On the topic as an update on the antibody-mediated rejection. Over to you, ma'am.
So thank you, Mahesha, for that nice introduction. Thanks to the organizers for this invitation, and thank you, Dr. Pallav, for putting this program together. So I would be talking on antibody-mediated rejections, and most of it would be basic because I understand that there would be nephrologists in the audience. So this is the slide which I always like to show at the beginning, because this gives you the spectrum of changes that one can see in an allograft biopsy and that one needs to be aware of. On the one side, you have the alloimmune reactions, which are the rejections, which could be acute or subacute or chronic. It could be T cell or antibody mediated. And on the other side, you have a variety of changes which can occur in the graft, many of which have been dealt with by experts in this forum. So rejections for the beginners are T cell mediated or antibody mediated. In T cell, we have acute, and you have the grades, that is 1, 2, and 3, chronic active, and a combination. Dr. Haas has sort of mentioned all of this in his lecture this morning. And I will be covering antibody-mediated rejections, and the classification now is active antibody-mediated, chronic active, and chronic antibody-mediated rejections. So just to put it very simply, that these antigens to which the antibodies are directed are predominantly the HLA antigens which are on the endothelium. So when a patient is transplanted, there is a possibility that you get these anti-HLA antibodies, and that triggers off the complement cascade. C4d is a byproduct of this complement pathway, and that gets bound to the endothelium and remains for some time. And that is the reason why we use C4d as a marker of this antigen-antibody reaction. The complement pathway itself goes on and causes cell injury by release by C5a, which attracts chemotaxins, inflammatory cells, and finally the membrane attack complex, which triggers off a host of inflammation. So that very briefly is how injury occurs to the endothelial cells in an allograft in antibody-mediated rejections. I thought it would be good for us to understand how our knowledge of ABMR has evolved. Pre-BANF and in the first BANF publication in 1993, we were only aware of hyperacute rejections, which happened immediately on anastomosis due to pre-existing antibodies. Very quickly, by 1997, they realized that you could get ABMR soon post-transplant, and that was called accelerated antibody-mediated rejection. In the 97 update, there was a good understanding of the two arms of rejection, the cell-mediated or the T-cell-mediated or TCMR, T-cell-mediated rejection, and the antibody-mediated rejection. With the knowledge of C4d and DSA, in 2005, the three sets of criteria were laid out, which I will be coming to in a minute, on diagnosis of ABMR, acute or chronic ABMR, had to satisfy the 3 criteria to diagnose the condition. In the 2013 paper, there was by then some knowledge that you could get C4D negativity in some cases, and that was C4 negative ABMR. And in 2015 Banff publication, if DSA was negative, you could call it as suspicious of ABMR, and transplant arteriopathy was also recognized as a form of chronic ABMR. By 2017, there was a major change in that C4D was recognized as being very specific and sensitive for diagnosis of ABMR. So what it meant was that we could substitute the DSA for C4D, which means that if you had criteria for ABMR satisfied and C4D positive, then it was enough and you could diagnose it as an ABMR. And in the latest Banff paper in 2019, there is a recommendation that in chronic active ABMR, it's a good policy to have a comment on the severity of activity and chronicity rather than just call it chronic active ABMR. Now we'll be seeing some of this in a little bit of detail. So antibody-mediated rejection, the 3 criteria are there. The first, the histologic features of acute or chronic injury, what we see under the light microscope. The second is the evidence that this injury has been caused due to antibody interaction. And for that, we use C4D as a marker. So if there is C4D, you assume that there were antibodies and the complement is activated. And that is the second criteria. Instead of C4D, you could have very significant inflammation, or you could use molecular assays to demonstrate the increased expression of gene transcripts of endothelial injury. Now, these assays have to be validated. And to my knowledge, I think there's no lab in India which uses this on a regular basis. The third evidence is that these antibodies are in fact directed against the transplant allograft. That is, they are donor-specific antibodies, and that you demonstrate the donor-specific antibodies, either HLA or non-HLA. And as I have mentioned, because C4D staining is so sensitive and specific, we have sort of done away with requirement for DSA. Again, to state that in our current practice, what we do is if you have evidence of injury that you see under the microscope, and if you have C4D positivity unequivocal, then you can confidently make a diagnosis of antibody-mediated rejection. And the criteria for the tissue injury. Acute injury, you must remember that these antibodies are directed against antigens which are on the endothelial cells. So you get basically endothelial injury. So wherever there is endothelium, you get injury. So glomerular endothelium, you get glomerulitis. Peritubular capillaries, you get peritubular capillaritis. Arteries, you get endarteritis. Injury can also cause thrombotic microangiopathy. Now, this is also mentioned, tubular injury, but in actual practice, we rarely see only tubular injury as a manifestation of an ABMR. What about chronic injury? Again, the endothelium is the target, and we get repeated injury of the endothelium causing a glomerular basement membrane multilayering or a remodeling. So you get duplication of the basement membrane, which is transplant glomerulopathy. In the PTCs, repeated injury of the endothelium causes multiple layers of capillary basement membrane, which is seen under EM. So that is peritubular capillary basement membrane layering. And in the larger vessels, you get the transplant arteriopathy or the arterial intimal fibrosis of new onset. So these are the features of injury, and you have C4D positivity. In the latest 2019 publication, like what I mentioned, it says that if you just give the clinicians a diagnosis of chronic active ABMR, it could confuse them and about the treatment options. because there is very limited information in that report on treatment options. And so there is a sort of recommendation that the diagnostic line could read chronic active ABMR with mild, moderate, or severe activity and mild, moderate, or severe chronicity, just like we do for a diagnosis of class 4 lupus nephritis. And you include the Banff lesion scores in the diagnostic line so that by looking at it, you can decide whether it's mild, moderate, or severe, though there is really no objective definition of what is mild, what is moderate, severe, and so on. This entity is again now in the ABMR list, chronic, what we call inactive ABMR. And when do we diagnose that? When we get evidence of chronic injury. That is, we get either transplant glomerulitis or peritubular capillary basement membrane multilayering on EM, but you don't have the second and third criterion at the time of biopsy. That is, C4D is negative, DSA is not demonstrable at that time. But what you do have is a past history of active or chronic active ABMR or a documented prior positivity evidence of DSA. So if you have a prior features of an ABMR and you have current chronic active changes, then you make a diagnosis of chronic ABMR. I would just briefly cover molecular tests. Endothelial gene transcripts have been around for some time, but like I said, they need to be validated. But the search is on for non-invasive markers, mainly urinary markers. And these are some of the markers which have been suggested for diagnosing both T-cell and ABMR, CXCL9, 10, granzyme, perforin, microRNA, and so on. What is becoming popular and will probably be available is the detection of donor-specific cell-free DNA. So by the droplet PCR and so on, either donor-specific cell-free DNA in the recipient circulation or donor-specific tissue exosomes can be detected, and those are supposed to be reliable ways by which you can diagnose both T-cell mediated rejection and antibody mediated rejection. And there is also a mention in literature of detecting HLA specific memory cells in blood. So I would just very, very quickly go through two classic cases to tell you how we actually diagnose ABMR. So 4 days post-transplant, past history of cross-match positive. So your antenna goes up for detecting ABMR, but recently DSA negative. And you can see that in this biopsy, there's not much inflammation, no tubulitis, but the glomeruli look quite abnormal. There is tubular injury, and this is a full-blown thrombotic microangiopathy. A lot of thrombi looking quite obvious in these capillary loops, very well made out on the trichrome stain, where they are seen as red granular deposits within the capillary lumina. So this was thrombotic microangiopathy. There was just this tubular injury, but if you look closely, there are cells between the tubules, and these cells are actually within peritubular capillaries. And most so, there is peritubular capillaritis as well. C4D was strongly positive, circumferential positivity in many capillary walls. And so this was a classic active antibody-mediated rejection. So you have the light microscopic criteria, G2, PTC2, and you have strong C4D positivity. This is a case late post-transplant, 2 years post-transplant, past history of ABMR, COVID positive, and a rising creatinine. And here, there's a lot of blue in the interstitium, so a lot of inflammatory cells in the interstitium. Note that even at this power, the glomeruli don't look quite normal. There is tubular atrophy as well, and around the atrophic tubules, a lot of inflammation. So this is IFTA, inflammation around atrophic tubules. And when you get IFTA, you start looking for tubulitis. And sure enough, there are a few foci of at least moderate tubulitis, at least 5 cells here, some 3 cells here, 1 cell there. So there is moderate tubulitis. So you have chronic active TCMR, But we need to look at all the compartments. So you look at the glomeruli and there is glomerulitis. There are endothelial cell swelling, lymphocytes within the capillary lumina, a thickening of the basement membrane. And if you look close enough at the silver stain, you can get at least some areas of duplication. So you get some transplant glomerulopathy as well as glomerulitis. Peritubular capillaries, you can see that at least 3, 4, 6 cells, many of them have lymphocytes within peritubular capillaritis. The artery is quite normal, no endarteritis out there, and C4D strongly positive in the PTCs and also along the GBM where the endothelial cells are. So they are marking the site of the complement activation. And so here you have chronic active T cell, but you also have a chronic active antibody. So you have the criteria of activity G2, chronicity, CG1, and PTC1 active, and you have a C4D positive as well. Now, if you go with the current recommendations, maybe you need to add a note saying that this antibody-mediated rejection has a component of moderate activity and mild chronicity. I mean, this is just something that you could add, which will help your clinician decide whether to go with active treatment or not. We all know that C4 ABMR can be C4D negative as well. And the reason for this, one could be technical, that because of the way it's been transported or whatever, your IHC hasn't worked. So always check first your controls to make sure that it is a true negative. Otherwise, the reason it occurs is that these antibodies also can elicit a complement independent endothelial and smooth muscle injury. So these antibodies are known to cause cytoskeletal rearrangement, intracellular signaling, can trigger endothelial, macrophage, NK cell recruitment, and can induce adhesion molecules and synthesis of cytokines. So all these inflammatory changes occur directly due to the antibodies, and that is the reason why C4D can be negative. What about if you get inflammation, microvascular inflammation? You get glomerulitis, peritubular capillaritis, but you don't get DSAs. Then can you still diagnose ABMR? Now this has been reported, and C4D negative. This has been reported both early post-transplant and late post-transplant. And it's believed that in early post-transplant, these patients have a better survival if they are DSA negative. But in late post-transplant, there is no significant difference. But what we as pathologists must remember that when we see microvascular inflammation, it is not pathognomonic of ABMR. We know that TCMR, very severe TCMR, if you look carefully, you could get microvascular glomerulitis, and those lymphocytes do come out from the capillaries. So you will get peritubular capillaritis as well. Any cause for a glomerulopathy, recurrent or de novo, could cause inflammatory cells within the glomerulus. So an MPGN pattern due to any cause can have glomerulitis, and TME again due to any cause, de novo, recurrent, can cause microvascular inflammation. So always to keep these possibilities in mind when you get a C4D negative and a DSA negative. And the important thing that we must now start thinking about are the non-HLA antibodies. All these years, the emphasis was on HLA antibodies, and they probably are responsible for most of the cases, but you do have non-HLA antibodies as well. So HLA incompatibility, as we know, is a major driver of alloantibody response in allografts. And we use HLA-DSA. We always look for HLA-DSA by many methods to look as a diagnostic criterion, as the third criterion for diagnosing ABMR. However, we know that ABMR can occur in the absence of detectable HLA-DSA in a large percentage, in 30 to 45% in literature. And even when grafts occur between identical twins who are HLA identical, you can still get an ABMR, and that is due to non-HLA antibodies. So what are these non-HLA antibodies? They are believed to be polymorphic antigens which differ between donor and recipient, and that's the reason why the recipient mounts an antibody reaction against them. And like the HLA antigens, they are expressed on endothelial cells, basement membrane, and extracellular matrix, which are exposed in allograft injury. And this is a very recent paper in KI, which has a very nice article on non-HLA antibodies. So basically, these non-HLA antibodies, the important ones are this one, AT1R, that is angiotensin 2 type 1 receptor, which is on the endothelium, ETAR, which is endothelin 1 type A receptor, again on the endothelium. Subendothelium along the basement membrane, you have the main antigens as MICA, MHC class 1 related antigen, and in the extracellular matrix, LG3, laminin G-like domain 3, and there must be a host of other antigens as well. Now, it is believed that these antigens, when endothelial injury occurs, either due to HLA antibodies or due to other injuries like ischemia and so on, these antigens are exposed, and if there is a difference between the donor and the recipient, these antibodies are elicited and they cause endothelial injury and histologic features exactly like your anti-HLA antibodies. And the most studied of them all is the AT1 receptor mediated antibodies. Now, this antigen is expressed on multiple cell types and endothelial cells. They're supposed to regulate water-salt balance and blood pressure. In addition to endothelial cells, they are also expressed on the immune cells, innate and adaptive lymphocytes. They have become important in kidney and other organ transplants and in native diseases in autoimmunity, endocrine disorders, GVHD, and so on. They are believed to act synergetically with the HLA antibodies. And the interesting thing is that these reactions often are complement independent. These antibodies cause direct injury, so your C4D may be negative. That is one important thing. And the other importance of this is that they could be potential therapeutic targets if detected. So if your rejection is through this AT1R mediated antibodies, then your anti-angiotensin receptor, like losartan, could be a therapeutic, could be a therapy in these patients. So this is the diagrammatic representation. You have these endothelial cells expressing these antigens, and then the anti-AT1R antibodies which occur, which cause direct injury through the MAP kinase, NF-kappa-B pathways, and so on. In addition, they are also expressed on the innate immune cells. So these antibodies activate these immune cells, activate cytokines, and cause inflammation. So this is supposedly the pathogenesis and the way that these antibodies cause injury similar to your HLA antibodies. And this is the Venn diagram in that same paper to say that if you look at ABMR, 49% could be only due to HLA antibodies, 17% could be only due to anti-angiotensin receptor antibodies, and 25% of them are a mix of both HLA and anti-angiotensin antibodies, and 9% are antibodies other than these two. So it's very interesting, and I feel that in the near future, we would have an assay for this anti-angiotensin receptor antibodies in those cases which are C4D negative and which are anti-HLA negative. Just the last few slides on ABO incompatible transplants, because that is occurring in increasing frequency across the country. ABO antigens are present in endothelium and distal tubules, and the antibodies occur naturally. So pre-transplant removal of circulating ABO antibodies is what has made possible this ABO incompatible transplants. So, so this would be very familiar to the clinicians in the group, that you have a protocol for removing ABO antibodies, which starts as early as 30 days post-transplant with rituximab initially, and later with other triple drug immunosuppression, physical removal of the antibodies, and so on. And after transplant, these antibodies, the ABO antibodies, are monitored. And if the level is high, then you would have treatment to remove these antibodies. And this has been very successful because only a minority develop ABMR due to ABO antibodies. And A2 blood group are supposed to be the safest because they express antigen less and they're less vulnerable to rejection. The highest risk is in the first 3 weeks, and what you get histologically due to ABO antibodies is very similar to what you get due to anti-HLA or the non-HLA antibodies. And in a very small percentage, you could have ABMR due to anti-ABO as well as anti-HLA antibodies. Having said all this, especially the data from Japan, where ABO incompatible is very widely practiced, the 1-year graft survival is 95% and the 5-year graft survival is 91%. So we have almost conquered this ABO barrier, and transplants are possible with great safety. For us pathologists, we need to remember that when we are looking at an ABO incompatible graft, you could get C4d positivity, and the positivity can last even up to 1 year or a little longer, up to 94%, and they can be present without inflammation. So it is some sort of an accommodation which occurs, and this is due to be because of the lack of FC receptors for the dominant IgM isotype of blood group antigens. And that is the reason which is why C4d can remain positive without any inflammation. So if you look at an ABO incompatible graft, if you have the features of rejection and if you have C4d positivity, not to jump to a diagnosis of ABMR without demonstrating the DSA antibody. So without demonstrating DSAs. So you need to look for DSAs in these patients and not to rely on C4d alone to make a diagnosis of ABMR. So in conclusion, I would say that ABMR is a significant complication still of short and long-term injury in up to 10% of transplants. Early ABMR is due to preformed antibodies. It's an anamnestic response and can be quite severe, which is usually should be avoided if you do a good cross-patch and a good DSA estimation and you work up your patient well. Late transplants are believed to be due to de novo antibodies, and they can be often combined with TCMR like the case that I demonstrated. Antibodies, you must remember, are usually HLA but can be non-HLA, and in the ABO incompatible group, the ABO antigens. In ABO incompatible allografts, C4d positivity can occur without inflammation, and when with inflammation, you have to do a DSA to confirm a diagnosis of ABMR. There are new molecular detection methods on the horizon. None are available for routine diagnostic use in labs, but hopefully in the near future, many more of them will become available, and they would also be these non-invasive methods like your cell-free DNA estimation for diagnosis of rejection. So I thank you once again, the organizers, for this invitation, and I leave you with this very nice picture of what actually happens in the endothelium in ABMR. So thank you again, and I would be happy to answer questions.
Thank you so much, ma'am. Thank you so much, ma'am. It's been such a lucid talk and actually directed towards the nephrology students. You have covered the entire topic of ABMR from the very beginning till the very end, probably have left nothing to answer. The only comment or request I wish to make to the pathologist friends is that time is of essence when you are handling a case of suspected ABMR in the initial post-transplant period. So Dr. Pallav Gupta definitely at our center has been very cooperative. He ends up answering our queries on the first and maximum the second day. So that is all I wish to say.
Yeah, I agree. Sorry. Yes, Mahesh.
That was a very wonderful talk, ma'am. Just a query in the relevance of this new paper in 2021 KI, where they have talked on the angiotensin receptor. Is there any, I'm sure there wouldn't be much literature before the COVID started, but in the off late, any cases in literature about the COVID influencing the process of rejection through that mechanism?
Correct. Very, I think, yeah, very intriguing and interesting. Well, whether I think even you have had, and we have seen cases with a history of COVID and very florid rejections, both T cell and antibody mediated. And now that you mention it, the antibody mediated have been classic in the sense they have been C4T positive, which is why we've diagnosed them. It is possible. I think it's worth going back and if we can get some serum or something from these patients, it would be because there was a lot of talk about angiotensin receptor when COVID first started. That people taking losartan and stopped taking them, and I think we went through that whole cycle in the beginning. Yeah, very very intriguing. It is possible that COVID injury to the endothelium is probably exposing these non-HLA antigens as well. It is, very interesting.
We seem to be running out of time any which ways. So I think I should be thanking Dr. Kote and Dr. Pallav Gupta for organizing such a beautiful one-day session. So I think back to the organizers now.
Thank you, Doctor. Thank you, Chairperson, for your valuable time.